Talley. I'm a urologist with Urology San Antonio. There's actually 24 guys in my group. We're actually 21 guys and 23 gals. We cover the city, have offices at the northeast, the southeast, the downtown, the medical center, and out at the north central. And so probably some of you know some of my partners. But what I wanted to talk to you today a little bit about was just men's health issues. I call it what men need to know and what men a lot of times don't want to know. We're very, how shall I say, we're pig-headed. A woman are very used to going to the doctor. They get their pap smears and their breast exams every year, and that's why they outlive us by an average of about 8 years. We men getting us to the doctor, you got to put a gun to our head, or basically we have to be pretty much dead. But I want to talk about 3 of the most common issues that I see in men. Some of these issues are exceptionally easy to treat. Some of them are a little more complicated, but have made a real impact on men's lives. Those are the things that we commonly hear in the news today: prostate cancer, enlarged prostate, which is also called BPH, and erectile dysfunction. So let's start off with the big thing, prostate cancer. Let me just give a little background about what the prostate is. The prostate is a gland that you can see here in the drawing. It basically is shown here. The prostate's basic function is to make secretions for ejaculation. This is the prostate here, and basically the bladder is above it, the urine is here, and the urine comes through the middle of the prostate and out when you urinate. It's, like I said, its main goal is making fluids for ejaculation. Most of us men, once we go through the childbearing years, our prostate just is not doing us much good except getting us in trouble, and it goes on to cause a lot of problems. So what is prostate cancer? A background, what is cancer? Cancer are basically cells growing out of control. I give people this analogy. When you think about cancer, think about your grass in your yard. You got grass, it grows, and occasionally you get a weed, and it just starts growing out of control. And that's what cancer cells are. They're cells that are growing out of control. People say, why is this? There's a lot of theories about this. One of the biggest theories, and I explain this to patients, is we make cancer cells throughout our entire lifetime. Our body's immune system recognizes those cancer cells and kills them. What happens in some of us as we get older is we develop cancers, and that's why we tend to find, particularly in certain types of malignancies, the younger you are when you get a cancer, the more aggressive they tend to be. Because as we get older, our immune system doesn't work as well. That's why we get more, as you get older, you get more prone to get cancer. When young people tend to get cancer, they tend to be more aggressive, more high grade, and be a problem. So that's what cancer cells are. They're cancer cells or cells that are growing out of control. Now, prostate cancers are cancers that start in the prostate. We talked about this earlier. They usually start small. They are usually very indolent for a long period of time, and then they begin to grow. And so getting them early is the big key to treating them. They generally start in the prostate. They extend out locally to the lymph nodes, and then they can go to the bone and the other parts of the body. Here's some cancer facts I think very, very interesting. It is the leading and the #1 cancer diagnosed in American men today, by far. But it is the 3rd leading cause of cancer deaths. #1 cancer death is still lung cancer, and #2 is colon cancer. Prostate used to be #2. If you actually look at the incidence of prostate cancer, it keeps going up, yet the cause of death is coming down. And the reason for that is early detection and early treatment. If you look at men across the nation, we're living longer. There's no question. The statistics show that we're living longer, and that 1 in 6 men will develop prostate cancer. We can talk about that in a minute, because in the older man, and I used to think, what was old? I mean, I can tell you, when I was 12 years old in the church youth group that I was in, I thought people 20, they knew the ways of the world. And when you're 30, man, you must be just ready for the nursing home. And one of the girls in my office, they told me, she said, I'm turning 30. I said, you're a child. I have shoes older than you at home. So it's what is old. But I want to talk just a bit about what is the, quote, older man and the incidence of that. There's over 40,000 deaths each year attributed to prostate cancer. The problem that I get in when I discuss with men about prostate cancer is guys say, Doc, I'm not having any symptoms. I don't have prostate cancer. And my #1 answer is the #1 symptom of prostate cancer is there are no symptoms. If you show me a man that has, and I said this, who has symptoms from his prostate cancer, that's a man who's in big trouble. Early detection is the key. There's no question that so many guys say, I feel great, I'm not having any problems urinating. I see this on the advertisement for certain medications and certain screenings that if you're having symptoms, notify your doctor. That's a problem, because most of the guys I see don't have symptoms, and that's when you want to get it, is before they have symptoms, so that you can treat those guys and that they will do well. So who's at risk? Every man is, but there are certain age groups that are higher than others. Men over the age of 50. Race does play a role in this, no question. African American men are at a much higher rate than Caucasian men, and a family history. There is some incidence that shows that diets high in saturated fats may increase the risk. What I tell men is this: If you have a first-degree relative, that is a father, a brother, a cousin, or an uncle, really cousins are secondary, but brother, father, or uncle have prostate cancer, you have an increased risk. You show me a man, there's been some studies to look at, if you have 2 first-degree relatives, your chance goes up. If you have 3 first-degree relatives, so if you're a man here and say, hey, my father had prostate cancer and 2 of my brothers had prostate cancer, I can almost guarantee you're going to get prostate cancer. Had a guy in the office the other day, he had prostate cancer, his brother had prostate cancer, and the other 3 brothers, all 3 got prostate cancer. And I told his boys, I'm probably going to biopsy you when you're 40. I mean, and he was a black gentleman too. So the risk is much higher. If you show me a black gentleman that has a family history, even more high. My father had prostate cancer, so my risk is higher. So there's no question that it is. Diet, there's been a lot made of herbal supplements, vitamin supplements. The only thing we know for sure, there is some data that supports that zinc, which is found in high concentrations in your prostate, may help, and selenium. But there's been no definitive answer, does it prevent prostate cancer? I know you see guys touting their supplements on TV. It's your money. You know, P.T. Barnum said there's a fool born every minute. So if you want to spend your money on it, you can. There's been no data to support that really makes any difference. So early detection, like I said earlier, is the critical part. Now, what are the early detection? PSA and digital rectal exam. Now, PSA is easy. It's a blood test. Draw a little blood out of your arm. We send it off to the lab. Digital rectal exam, as you said earlier, the finger makes men most nervous. Let's back up and talk about PSA first of all. PSA is a simple blood test that we do. We draw the blood. We check it. Little discerning information here. You know, if you read the data, it's basically, oh, my PSA is less than 4. PSA less than 4, when Yang sort of developed this back in the 1980s, it was 79, you looked at, they did thousands of men, they figured up the PSA, and the average PSA was about 4, and that's kind of what they went with as normal. That's not necessarily normal. What we found now is there's what's called an age-specific PSA, which tells me, man walks into my office, he's 50 years old, and he has a PSA of 4. I am very nervous about that man. Man walks into my office, and he's 75, and he's got a PSA of 5. I'm probably not worried about that guy. We know that as you get older, we'll talk about this in a minute, your prostate enlarges, and so the PSA does go up. So what we're showing now is that any man that I see in my office under 60, and a lot of my guys under 65, if their PSA is less than 2.5, they probably need a biopsy. Because what we have found is that if you wait till it gets to 4, that the risk of missing a cancer is significant for those patients. The digital rectal exam, people say, why can't you just do the blood test and skip the digital rectal exam? And the answer to that is they go hand in glove. I can't tell you the number of guys that come into my office that have an abnormal PSA, which is still the most common reason we find the prostate cancer, have an abnormal PSA but a stone-cold normal rectal exam. But I have a significant number of men who have a stone-cold normal PSA when I feel their prostate. I said, you know, this isn't normal. A very good friend of mine from church called me and says, hey, my primary care doc needs to send me to see, my PSA is 1. And he found something irregular on his prostate exam. And I said, yeah, this is abnormal. Sure enough, he had prostate cancer. So you can't just use one without the other. They are working on some new and more specific blood tests, not available yet. We hope that in the future we will have a blood test or a particular test that will alleviate doing a biopsy. But until now, if one of these is abnormal, you know, the gold standard is a biopsy to make sure. Like I said, the PSA is a simple blood test, and we just sort of touched on the issues of the fact that it's measured. It's a protein made by the prostate. And like I said, 0 to 2 is about normal for any man under about 60 to 65. Now, there's been this real debate on what is normal and what is not normal. It varies, and we know this. And doctors, we know that it's not 100% normal. I have guys that have PSAs that are, you know, kind of on the borderline, and I may repeat them. Some guys walk into my office, a guy today, he was 59, and his prostate PSA was just a touch high, and so I may repeat that PSA and just see, because I don't always go by 1. But, you know, guy today, PSA was a little, it wasn't too bad. It was 2.5, 2.3. But his father had prostate cancer, and his prostate didn't feel normal. Those guys need a biopsy. Biopsy is pretty simple. We do it in the office. But when you're considering how to, and that's part of the art of medicine. Medicine is not a science. It's an art. And every person is different. Every client is different. You kind of have to meld that and come up with what works best for those patients. For the digital rectal exam, this is what most men fear. Basically, it's a very simple exam by which you take a finger and you put it in your bottom. It should not hurt. It should not be uncomfortable, but it gives us an idea. There's a lot of things we pick up. Abnormal prostate exams. I get several guys that come to see me on a regular basis. Every year I find 1 or 2 guys. They come in to get their prostate exam. They're a new patient. They're Somebody sends them over to see me, their mother, their wife, somebody, and I do a prostate exam. Prostate's normal, but I feel something abnormal in their rectum. They've got a rectal cancer. So you pick up a lot of things, not just the prostate, but some other things you may miss if you don't do a rectal exam. So who should be tested? We talked about this earlier. These are not hard and fast rules. These are just sort of general recommendations. Any man 50 years older or older every year needs a rectal exam and a PSA. If you have a family history, I usually start a baseline at 40, and African Americans, like I said, 40. If you have a family history and you're African American, I've had a few of my guys, like this family I was sharing, I'd recommend it at 35. They needed a baseline. I'm 45. I've been getting my father was diagnosed when he was 60. I get a rectal exam and a PSA every year, and started that about 8 years ago. And thankfully, I've not had to have a biopsy yet, and don't look forward to that. But if it has to be done, it has to be done. This is one of my favorite slides a friend of mine sent me. That you wouldn't be here if it wasn't for early detection. There's no question. Early detection is the key. It's like I tell people, it's a lot easier to head off. You know, my grandmother used to say, an ounce of prevention is worth a pound of cure. I get guys in my office every year, and it really is, it just breaks your heart sometimes to sit down and talk with a guy that I just sat down with about 2 weeks ago. He came in to see me with a PSA of 25. And he had been seeing somebody, and his primary care doc had been trying for years to get him to come in and see me. And finally, his wife she put the screws to him and broke down. And I biopsied his prostate, and it's full of cancer. And I really can't cure this guy at this point. And it's really heartbreaking because, I mean, that's a guy that 3 or 4 or 5 years ago, had he come in, I probably could have made a difference in him. But, you know, you can only deal with what you get. It is sad because so many people are afraid. You know, I never it's the part of my job I always ask the Lord, never let me get used to telling people they got cancer. Because if you do, you've lost your compassion. But what I will tell you is that if you tell a guy they've got cancer and you deal with it, it's a lot easier to deal with a problem when it's small and not big than once the horse is already out of the barn. Because by that point, you're doing supportive care and palliative care. You're not doing curative care. Enlarged prostate. This is something you're starting to see more of men become aware of. A lot of direct-to-consumer marketing for drugs for enlarged prostate. I want to talk about that a little bit and sort of where we go with that. An enlarged prostate, it's also called BPH. It's a very normal process that begins in all men at about the age of 30. I get guys in my office all the time. They're 55, 65, 75, 85. Doc, I'm really worried I got an enlarged prostate. And I look them straight in the eye and I said, if you're 50 and you're in my office and your prostate's not enlarged, something's wrong. I tell them, getting an enlarged prostate is like getting gray hair and wrinkles. It's going to happen to all of us, okay, to some degrees. Now, the size of the prostate doesn't always reflect a problem. I have guys that have huge prostates, and the biggest problem that we see from prostate is not prostate cancer or an enlargement. It's problems urinating. And we have to define this. Every man gets enlargement of the prostate as we get older, okay? Some men develop cancer, some men don't. Men with enlarged prostates, some have problems urinating and some don't. And it's totally unpredictable. I have guys in my office that are 55, the prostate's not that big, but they're getting up 4 or 5 times at night, the stream's weak, can't pee, and it's driving them crazy. I get guys that are 90 and they say, Doc, I get up once, but that's only because I got to let the cat out and I go back to bed, you know? And so it's very variable. The size of the prostate is not always indicative of the treatment that needs to be undergone with this. But it can lead, the biggest thing that you get with the enlargement of the prostate is urinary problems. And this sort of gives you an example. It's sort of a split view, and what it basically shows you is this. This is the prostate, the bladder here, and the urine goes right through the middle of the prostate. This is what we get with enlarged prostate. It basically blocks you off. I'm very simple. I explain this to people. Think of your prostate as the sort of the tunnel that goes through. When you have a rock slide, you can't pee. We need to get you peeing better, okay? It is amazing to me how many men I see with problems like this, because prostatism, enlarged prostate, voiding difficulties, you'll hear us call them LUTs, lower urinary tract symptoms, bladder outlet obstructive symptoms. It's a very insidious process. It starts very slow. You don't just wake up one night, oh my gosh, I'm having problems. If you talk to guys, the best people to talk to are their wives. Because I'll say, guys, how many times do you get up at night? Once or twice? She'll go, you know, how's his stream? Pretty good. She's going, horrible stream. Our wives are honest with you. You know, they'll tell you he gets up 5 times at night. He stands at the bathroom for 20 minutes. You know, I've been to ball games. I've been out to restaurants, and there's some guy standing there leaning. Just standing there saying, "You okay? I'm fine, Doc. I'm fine." You know, and so although after the senator last week, I'm a little nervous about talking to people in the restaurant. But it's one of those things that so many men, it's an insidious, slow process. You don't just wake up one morning and have problems. It's slow. And most guys, when you talk to them, will say, you know, Doc, if I'm really honest with you, this has been going on for a long time, and it's just progressively getting worse. And it's a slow process, but it is very treatable. What are the common symptoms of an enlarged prostate? Frequent and urgent need to urinate. Guys say, Doc, when I got to go, I got to go. When I go to church, when I go to the mall, I know where every bathroom's at. I plan my trips around that. They'll tell you, when I start, it's kind of, I call it stutter avoiding. They go, and they stop, and they go, and they stop, and they go, and they stop. It's like, you know, it's funny because, you know, I have an 8-year-old son, and when he goes and pees, it sounds like someone's got a water hose in there. And in some of us, we're a little slower as we get older, and that's very normal. Guys will say, you know, like, I just don't feel like emptying my bladder well. I go and turn around, and I go to the bathroom, and I walk right back in. And so, and the most common thing you see is the getting up at night. The guys go from once to twice to 3 to 4 times. Things that you need to understand about the getting up at night. I tell people, the getting up at night is the thing that guys notice the most, but it's the thing that least returns to normal. We've looked at studies looking at both men and women, and I get guys in my office all the time. They say, Doc, the stream's good, I empty good. I get up twice at night. Does that bother you? No. Studies have shown in both men and women over the age of 60, the average is getting up twice at night. Probably has to do with the fact that as we change, the nerves to our bladder change, and we tend to go more frequently, and that's just the nature of the disease, of the nature of the aging process. As one of my patients says, Doc, getting old is not for wimps. So that's one of the things I tell you. But that is the last thing to get better. But I can get guys, you know, the guy that's getting up 6 or 7 times a night, we will get him better. But for those of you with voiding symptoms, this will be the symptom that gets, this will be the last symptom to improve. Okay? And I tell guys, you're never going to be 20 again, but we can make you better. What are the treatment options? They range from all kinds of options. Watchful waiting, not doing anything. I have a significant number of my men that I talk to them, and I tell them, the worse your symptoms are, the better you're going to do with therapy. The milder your symptoms are, you're not going to get a whole lot. You know, the guy that comes to see me that gets up twice a night, his stream's a little slow, but he empties okay. He is not going to get a lot of improvement out of any kind of medical therapy I do for him. Medication, the big drugs you see now, they're advertising Flomax, Avodart, Proscar, Erectile. They categorize into 2 categories of drugs. Let me just talk about that because somebody may be on one of those drugs. The first type of drug are what we call alpha blockers. Okay, drugs. The 2 common drugs that you see are Flomax, and the other one is Erectile. There's also some generics of what we used to call these are the newer generations. The earlier generations was a drug called Cardura or doxazosin, and a drug called Hytrin. It was also called Terazosin. And what they actually do is relax the prostate. They do nothing. All 4 of these categories do nothing to shrink the prostate. They actually help the prostate relax so that you can empty better. Okay. The second category of drugs are called 5-alpha reductase inhibitors. Basically, these are the drugs like Proscar and Avodart. They actually shrink the size of the prostate. And people say, well, which one do you decide to use? It depends on the type of prostate. It depends on the voiding symptoms. And so that's kind of where the art of medicine goes. Sort of a thumbnail thing. The Flomax, the Alfuzosin, the other drug was called Erectile. They're sort of a quicker to get things going. The 5-alpha reductase are more of a long-term drug. I have a significant number of my guys that have been long-term Flomax or long-term Erectile and doing great. If I got them peeing better and they're happy, don't rock the boat. Tend to be a lot more sexual side effects from the Avodart and the Proscar. The Avodart and Proscar guys tend to get a little breast tenderness or enlargement, and they can have some problems with erectile dysfunction. So that's one of the things. Cool thermal therapy has become one of the newer things now. It's actually microwave therapy. And no, Joe Guy says, does it ding when it's done? No, it doesn't. It's actually a catheter that we actually can do this procedure in the office. I have 2 of my partners who have a very keen interest in doing this. Basically, you put a catheter in the bladder. It stays in for about 35 minutes and actually sends microwaves into the prostate, helps the prostate shrink and open up and pee better. I tell the men that have this, your urination will get a little worse before it gets better. But in about 80% of men who have this, okay, they actually are able to get off their medications. And then the last one is surgery, the quote, ream job, the roto-rooter, the core job, whatever you want to call it. This technique has made some significant improvements in the last several years. Used to, it was a big, bloody, nasty operation. With the advent of most of us are now using a laser for this, it has significantly decreased our blood loss. And most of my patients who have this have their surgery go home the same day, catheter in overnight, and they're pretty much, back to speed. I will tell you, this used to be the TURP, which stands for transurethral resection of the prostate, was the #1 procedure performed on men. Okay, the number of this procedure has dropped off dramatically because of medical therapy. I tell guys, I'm not a rocket scientist, but if I've got the option of having an operation or taking a pill, I tell you which one I'm going to do. I'm going to take a pill. But there are still some men that do need surgical intervention to help their problem. Erectile dysfunction. Now, this is a very sensitive issue for most men. I have no problems with saying penis or erectile dysfunction. It's a problem. It's a natural God-given talent that God gave us. A friend of mine, his name is Steve Arbach, who's in California. He used to say, "I'm here to be an ambassador for good erections." And so that's what I'm here for. I get guys in my office all the time that I talk to about erectile dysfunction. I bring this issue up. We discuss the issue very openly. I have some guys that they want to talk about it, and I will point blankly ask them, "Do you have problems with your erections?" And they're like, "No." And so, fine. And this goes on 3 or 4 or 5 years, and they come to me and I say, "What brings you in, Dave?" "I got to get my erections fixed." "When did this start?" "Oh, about 4 years ago." It's like, "I've been asking you this every year." "Well, okay, doc, it's fine." And so every patient, you got to kind of figure what their comfort level is with discussing this. But I want to sort of touch on erectile dysfunction. I know with the advent of drugs like Viagra, Cialis, Levitra, the direct-to-marketer consuming the advertisements you see with the Jay Lenos and the David Lettermans, it's become quite the topic of television. A lot of it is good information, a lot of it is bad information. I will tell you that when I was a resident medical student, we had basically only for erectile dysfunction was an operation. And the amount of operations we did was significant. The amount of operations we're doing now has really dropped off due to the advent of recent therapies. So what is erectile dysfunction? Erectile dysfunction is the inability to maintain or achieve an erection adequate for sexual performance. You hear it called ED, you call it impotence. Erectile dysfunction has become sort of the common phrase. Not so much that it's politically correct, it's more scientifically accurate. It's funny, I tell people when you talk about erectile dysfunction, it's a issue that, people, they don't mind talking about their erectile dysfunctions. They don't want to talk about their impotence. And so I think that's, the news media and with, like I said, the Lettermans and the Lenos have made people have the ability to discuss this. It's funny when you talk to guys about this, some of them they want to talk about it. I can't tell you the number of guys that come to me, their wives want to talk about it. And so when I talk to them, I really like it if a guy brings his wife when we talk about his erectile dysfunction. Because I tell people, sex is a team sport, okay? When I talk to guys about their erections, I sort of say it this way. Think of your penis like a hydraulic pump. Blood rushes in faster than blood rushes out, and you get an erection. When we have problems with our pump, we just don't get the erections. People often ask me, what are the common things that cause erectile dysfunction? Well, it's very common, as you can see in men over the age of 40. I tell people they're what I call the big four for erectile dysfunction. Okay? Number 1 is aging. Number 2 is smoking. Number 3 is diabetes. And number 4 is high blood pressure. And with high blood pressure goes sort of what I call it's the fifth, but it's the blood pressure medications. Okay? A guy walks into my office and he's 75 years old. He's been a diabetic for 20 years. He's on 4 antihypertensives, and his idea of exercising is walking down the store to buy 2 more packs of cigarettes, and he can't understand why he's having problems with erections. Okay, we need to talk here. I have guys all the time, which I tell them, they've had 4-vessel bypass, and they've had 2 bypass operations, and they're having problems with that. I said, look, the vessels in your penis are much smaller than the vessels in your heart, and when you start having problems up here, you're having problems elsewhere. And so it's a blood flow phenomenon. We can make your erections better. I tell people, expectations are 90% of what I do. If a guy comes to me for an operation for his kidney, for his penis, for whatever it is, if he thinks I'm going to make him 25 again, he's not. I think when you're realistic about your expectations treating erectile dysfunctions, then understand that. And so I think that's the thing that it has to be discussed when you discuss with patients. So like I said, these are the things: age, diabetes, hypertension, smoking. From time to time, the big thing that we're seeing now, guys have had radical prostatectomy or prostate cancer surgery or radiation. And I see a lot of men who have, if you start talking to them, a guy comes into my office and says, well, how are your erections? And he's a young guy. And you say, well, my wife just left me and I lost my job and my kids hate me. Well, okay, we have to back up a little bit. There's some other issues dealing with. And so there's a lot, it's a multifactorial thing. Can be hormonal. One of the things I always check on my men, you need to check a testosterone, and then you need to back out. Certain men that are on certain drugs, like some of the SSRIs for depressions, Prozac, Zoloft, Paxil, can cause erectile dysfunction. Okay? I think that, like I said, the expectations are what you really have to deal with when you talk to men. Like I said earlier, this sort of gives you an idea of sort of a diagram here. This is what, for example, this is what you're in the heart. This is kind of compared to this size versus this size in your penis. So if this size is getting blocked off and you're needing to have 4 or 5 vessel bypass surgery, you can imagine that this one up here is already going to be obstructed. There are a lot of treatment options. I have to tell this to people, when Viagra came onto the market back in '98, it's been out for about 9 years now, it made a huge splash. Every man showed up in my office and he's thinking it's going to make him the new Wonder Man. It's not. I tell people this is a very interesting thing. Everybody has heard, if you were to go to most places, what is Viagra? Most people know what Levitra and Cialis are, but Viagra is by number one in the question. If you went to in the world, there's actually a study being done. There are 3 companies in this. If you go anywhere in the world, the number 3, 1, 2, and 3, and they're listed as far as branding. We're talking about branding. Ozarka. Okay. You know what the number 1 in the world is? Number 2. Very good. Coca-Cola is number 2. McDonald's is number 1, and Viagra is number 3. Isn't that amazing? Here's another little fact for you that most people don't realize. Until about 3 months ago, Viagra ran their first commercial, their first printed ad, saying what they did. Viagra is for the treatment of erectile dysfunction. Until that point, they had never said what they were for. They didn't have to. I mean, gosh, that's a marketer's dream. And the reason is when you say what you're for, if you say, I am XYZ and I am for, hair growth, you have to do what's called fair balance. You have to say what the side effects, even if they're small. And that's why when you see the Cialises and the Levitras, they talk about an erection lasting for more than 4 hours, which I have personally never seen. I've seen one case report. The sinus medications they talk about, whether it's Claritin or whatever, they spend more time telling you about the potential side effects than what they actually do. It's called fair balance. It's actually dictated to those what they have to say by the FDA. And so that has become a big deal. But be that as it may, the non-prescription medications, they work very well. Let me just sort of talk about those real briefly. These drugs are called PDE5 inhibitors. They work to give men better erections. Now, I tell guys, they're not going to make you have super erections. If a guy hadn't had an erection in 7 or 8 years, it's going to have a guy's problem. The penis is just like your arm. People say, what do you mean? If you put your arm in a cast and you leave it in the cast and you never use it, when you take it out of that cast, it's going to be stiff and it's not going to work. Guys that haven't had erections in long periods of time are the most difficult men because that tissue that gets engorged with blood to give men erections gets scarred and fibrosed. The old theology of use it or lose it is absolutely true. So a guy that walks into my office that hadn't had an erection in 10 years, that's a guy that's going to be a difficult problem to get his erections going again. These pills may not work. But what these pills do is they work to inhibit an enzyme to help the guy get better erections. I have to explain to guys, if you take this pill and just stare at your penis, nothing's going to happen. Okay? I can't tell you the number of guys that said, yeah, I took a Levitra or I took a Viagra and I just watched my penis and nothing happened. Okay, we need to have a little education here. Part of the problem, and in their defense, are a lot of primary care doctors and family practice doctors, when they give this to patients, feel very uncomfortable. I have some of my partners who have no interest in talking about erectile dysfunction. Because when you talk about erectile dysfunction, you have to ask them very pointed questions. Some of them can make people a little uncomfortable, but you do. I mean, the guy that says, I see this quite often. I had a guy in my office. You have to ask him questions. Are you in a relationship? When was the last time you had an erection? Can you get it? When did you have an erection? Do you ever have an erection? No. What do you take? You start to ask questions like that. My wife left me 3 years ago. Okay, there we have to back up and sort of readjust. And so I think it's you have to ask some very pointed questions, and you have to kind of tease through all the stuff. But you take the pill. It takes about an hour to be effective, and it basically takes some sexual stimulation, some foreplay. People say, what are the difference between the 3? They're basically all the same. They all work effectively. The big difference I think that a lot of people will discuss, and I have personal preferences we discuss, is the Cialis. One of the things I like about Cialis is it has a 36-hour half-life. And that means it has 36 hours of efficacy. Now, first of all, you're not going to have an erection for 36 hours. But what it does is it gives guys a sort of a broader window of opportunity, if you will. But for me to stand here or for any rep or any company to say, hey, we work better, we give better erections, they're blowing smoke. Okay? They all work well, they're all safe, they're all effective. Every person, and it's like I tell some people Advil works well for, some people Aleve or Tylenol works. You kind of have to sort of move around and see what works best for those patients. If a patient comes to my office, and that's usually my first-line therapy or the oral medication. If that doesn't work, we move to vacuum erection devices or what we call injection therapy. Basically, vacuum erection device is a clear plastic cylinder, has a little rubber band at the base that you put over the penis. It's got a little hand pump that you pump pulls the blood like a little suction cup into the, and the little rubber band fits around the base of the penis. A lot of guys don't like it. It is a little mechanical, have some numbness of the penis, and it's a dealer's choice. And then injection therapy. We actually teach you to give yourself a shot. And now, most men sort of cringe when I say this, okay? We teach you to give yourself an injection into the penis, okay? If you think of my fingers being the penis, you actually give it on the side of the penis. Now, most men are like, I'm laughing at the ladies. The ladies are like, how? Well, I told this, and one of the nurses goes, I don't have one of those, and it still makes me hurt. You would absolutely be stunned at most men when they do this. You're going, that didn't hurt at all, Doc. You're right. Sometimes it feels like a little pinch. What it actually does is we give some vasodilatory medications. It actually causes the blood vessels to dilate. It gives a very natural erection. Gives a very good erections. The erections last anywhere from 15 to 45 minutes. Okay? Keep the medication.
Do a combination.
You can, but the price gets a little steep. That's one of the real limiting factors. If you look at the vacuum device, the pill and the injections, yeah. Usually when you use the injections, you don't need the pill. So you'd just be double booking. We did some studies looking at that. The pills range from anywhere from $10 to $12 a pop. The injections range anywhere from $4 to $8 to $12 per injection. Okay. The medication you keep in your refrigerator for the injections, and whenever you get ready to give yourself a shot, you give yourself a shot and you're good to go. If men, I tell them, if you try the injections and you don't work, you can always try the pump. If you try the pump and you don't like it, you can always try the injections. And this is after we've tried the pills. Lastly is a penile implant. It's called a penile prosthesis. There's a couple different types of this. I quit doing this operation about 4 years ago. I have a partner by the name of Roy Jones. Roy is probably one of the most preeminent implant surgeons in the country, and I send people to him. So, like you were saying though, when would you use both of them together? The answer is you can. You really don't need to. If guys get good erections with, now I have guys that they take the pills with the pump, because the pumps, it's kind of a one-time cost to get it, but I've got a few of those. Most guys, if the pills work for them, great, then they move on to either the injections or the pump, but using them together. There's actually a new drug they're looking at coming out with to use along with the pills. It's still in the phase 2 trials, but the problem is that one's going to be the cost. You're looking at $20, $25 a pop. There's one drug I did not mention on here. It was a drug called Muse. It's actually a little capsule-looking thing that you actually put inside the urethra. It gets absorbed and causes erections. It causes a lot of burning, and it's about $25 a hit. So a little pricey. In fact, most of the pharmacies don't even carry it anymore because it's just most people don't use it. That being said, I'd like to open the floor up to questions. If anybody has a question or a thought or curiosity, I'm here at your disposal. How does it work? And that's a good question. There are two types of implants, okay? One is called a semi-rigid we call it a semi-rigid. We jokingly refer to it as the Ever-Ready, okay? It works, think of it like a gooseneck lamp. Anybody here know what a gooseneck lamp is? I said that once in a group, and the over 40 crowd, we all knew what it was, but basically you bend it down when you're not using it, you bend it up when you're ready to use it, okay? The other one is called an inflatable. Basically, it's a component. The penis has two erectile bodies, called the corporal cavernosum. You put two cylindrical implants in them. You put a little pump. It's all internal, inside the scrotum, and a small little saline-filled reservoir up in the abdomen. All of this is done through a small little incision in the scrotum. Basically, the pump is inside the scrotum. It kind of feels almost like a third testicle. When you're ready to have sex, you grab the pump, pump, and it comes up. And when you're done having sex, you let it down. The one advantage, one of my patients tried, when you have an orgasm, it doesn't go down, so it stays up. So that's pro or con, depending on your point of view. So, no, not until you squeeze the little. There's a little. You feel a little bump on the thing. You squeeze it, and it goes down. I know people say, huh? I'm often convinced that the Lord providing the world's still around in 1,000 years. There's going to be when you talk about doing implants, there's going to be a guy that's going to be some archaeologist. He's going to be going through some deal. He's going to find a casket and he's going, good look at the torture they inflicted on these men. What kind of information were they trying to get out of them? Yeah, exactly. Yes, ma'am.
So my husband's 48.
And his father had prostate cancer, which was diagnosed very early.
Right.
So I would think that he would need to go in and get examined, and I can't get him to go.
It's like I tell guys that when I counsel with them about their erections, they're worried when they get prostate cancer, they're worried about losing their erections or having problems. I said, look, no matter how much you like doing what you're doing, it's not doing you any good if you're in a coffin. Because I tell men, if you've got a family history, he needs a rectal exam and a prostate and a rectal exam and a PSA. Some of the studies would say 45. If I've got a family history, I tell guys 40. Because, it's a lot easier to do a blood test and a rectal exam and find out it's stone cold normal. And say, hey, see you back here. Maybe I'll see you back 2 years since you're 40. Then just have a guy who comes in my office when he's 48, 49, 50 with stage C high-grade cancer that that guy's in serious trouble. So, I tell him, how do you like, and that's why I get back to my point. That's why I think if you look at women, I think y'all are much tougher than us, but women on the national average outlive men by 8 years. And I think a lot of it has to do with women are, from the time they're having babies, they're seeing their gynecologist, they're getting their checkups, and we men, we're invincible, we're Superman. No, but I tell him, put the screws to it, make him come. Okay? Ask him, does he like living and going out to dinner?
On the digital exams, do you think a general practitioner, family doctor, can do a good exam?
I'll be honest with you. There's several guys in this town. There's a bunch of them that I'm really impressed. Now, there's some of them that have no interest in it, and that's okay with me. They say, look, you need to get your prostate checked. Go see Talley. And I say, bring them in. I'll see them. But they'll go see Singleton or go see O'Neill or Salton, whoever's in my group, or any urologist in town. Go see them. And that's okay. I appreciate a man or woman who understands that's the limitations of their thing. I have some female practitioners, family doctors, but they don't want to do rectal exams, and that's okay. But I have some. I am truly amazed. This friend of mine that I was telling you about that I go to church with, his family doc picked this up. And when I felt of it, I said, Ray, this guy's good. I said, you need to keep on him. Because, there's a lot of guys, but I'm amazed. And I still get guys that come to see me. Their family doc felt something, and he'll call me up and say, hey, Dave, I'm sending this guy with you. His prostate, I don't think it's anything bad. I just want you to be sure. Because you do, I do 50 or 60 of these a day sometimes. And so it's like anything. And I'll feel of it, and I'll call him back. I'll say, hey, Bob, look, prostate's fine. It's just a little irregular on one side. It's nothing that I'm worried about. Because the prostates can be a little irregular. I tell people, if you look at people's faces, one eye's a little different, one ear's a little different. And it's not. But every prostate's different. But the answer to your question is yes. Family doctors, they can do an adequate, very good prostate exam, and they can do good PSAs and check all that. And if there's a question, they'll send you to see me. Yes,
once I reach 40, I'm very regular about once a year. When you get older, do you need it more than once a year or is once a year?
I really don't, not unless there's something. Now, I will start a guy, if a guy comes to see me with voiding symptoms, we talk about the BPH, enlarged prostate, I'll get him started on a medication. I may see him back in 3 months. Make sure he's PNK, maybe see him back in 6 months. And once I got him stable and he's good, then once a year's fine. The only guys I see on a more regular basis are the guys who I've had prostate cancer and been treated. I generally follow those guys every 6 months for the first 4 to 5 years, depending on how they're doing. PSA rectal exam every time, and then I'll back them out to once a year.
You can ask a question.
7 years ago, my PSA jumped from 2 the year before, to 6.2. I was sent by my family practitioner to a urologist, who then did the little test for a biopsy. 3 out of 6 were cancerous. I chose to do, rather than the therapy, I chose to do radiation, did the 37 treatments at CTRC. Now, 7 years later, that was in 2000, 7 years later, a year and a half ago, the last time they did a PSA, it was 0.6, and I was real happy with that. This last time I went, just 2 weeks ago, it was 21.2. This was very disturbing to the family practitioner. He sent me immediately to the urologist that I told you about. And he put me immediately on a little pill, Casonex, I believe. Yes, which is a hormone. He told me about that. Gave me another, I'm supposed to go back on the 6th, and he said at that time he was going to put a little implant in my arm through which he could give medication at intervals, I assume,
Well,
which is hormone.
What you're probably talking about, there's a couple of implants. There's one called Avantis and there's one called Viadur. When men have prostate cancer, and let me back up, you basically when it's diagnosed, if it's a low stage confined, you can either have surgery, you can have radiation, you can have there's a whole milieu of treatments. Sound like you had what at the time was confined prostate cancer, and I tell people, guys come to me when they have it, I said, can you guarantee you can cure me? I said, no. If you meet someone that guarantees, run from them.
Yeah.
Prostate cancer can always come back after surgery, after radiation. After surgery, sometimes we radiate, sometimes we give hormones. When it comes back and goes up high like that, that's a recurrence of the prostate cancer. And at that point, we really don't have any good conventional chemotherapy that people think of like with breast or with colon. So a man's testicles make the hormone testosterone, just like a woman's ovaries make estrogen. When women go through menopause or the change, their ovaries kind of burn out, if you will. That's why women have hot flashes and, you know, they may not all have a little mood swing. It's because their hormones are gone, okay? I always get nervous when I say this because I always look around, but that's why women have those. Men, our testicles make testosterone throughout our entire life, but prostate cancer feeds on that testosterone. And so when men have a recurrence of their cancer, or if they come in with cancer that's everywhere, the way that you do that is you turn that testosterone off. Now, there are two ways to turn it off. Is what we call a surgical castration, which is where we remove your testicles, or by giving you either a shot or an implant. There's 4 or 5 different companies that make it. They all pretty much work the same. They basically turn the testosterone off. Now, the shot you get, the implant you get, will basically turn off the testosterone that comes from your testicles. And that represents about 95% of all your testosterone. There's a small gland above your kidneys called the adrenal glands. They make about 5% of the testosterone, and that comes from your adrenal glands. And that's what the Casedex, there's another drug called flutamide that turns that off. Most of us use Casedex now. The flutamide has a lot of problems with diarrhea and nausea and GI upset. So you do the Casedex once a day. Now, the implant that they give, there's one that lasts a year, there's one that lasts 6 months, there's one that lasts 3 months. So they all work the same and they're all very effective.
Is that medication? Testicles and the adrenaline?
Yeah, it's what that medicine does to it. Basically, there's a hormone in your brain. As far as how does this medication work? Yeah, the medication works by this way. Your brain makes a hormone called luteinizing hormone. And luteinizing hormone goes down to your testicle and it says, hey, make testosterone, okay? So my analogy to this is like you turn that LH off and you turn off the testosterone. So it's like a light bulb. If the light bulb burns out, which would be you take it out, that's the analogy to the taking the testicles out. Basically, the shots is an analogy to hitting a light switch. It works exactly the same. Common side effects. You say, what side effects can I expect from it? You can expect 2 side effects from hormone therapy. You can expect erection problems, and you can expect hot flashes. Now, the erection problems, I almost guarantee all men will have that. The hot flashes, it's very variable. Some guys get them, some guys don't. It's totally, some guys it's bad, and some guys it's not bad. I always jokingly tell them, I say, to kind of make them feel, I said, if you're worried about sympathy from your wife, she's not going to give you. Most of their wives are grinning and shaking their head. I've been there, done that. So the hot flashes are usually very short-lived. After a while, they go away. Some guys, I get guys, they never have a hot flash, never even turn a hair.
He also did a bone scan, and I haven't heard any results about that.
Yeah, you were restaged. You get a bone scan to make sure. One of the risks is that you have a hot spot going to the bone somewhere, because that's where it can go. Probably with your PS, probably didn't, but you want to make sure, because if there is one, sometimes you do spot radiation to that just to keep it from getting what's called a pathologic, a break in the bone. But the bone scan was a restaging, and I'm sure he'll call you with that. Generally, I tell all my patients, if you haven't heard from me in a week, you call me back just to make sure, but if it's positive, they will let you know. But follow up with your urologist if he hasn't called you back.
No, he hasn't called back, and I'll go on.
How long ago was your bone scan?
About a week.
I'd give him until Tuesday, and if you hadn't heard from him, be knocking on.
Well, I'll go in on the 6th.
That'd be perfect. That's probably what what I tell patients is this, and every doctor is different. It's the art of medicine. Some guys, I say, look, I'm going to get an x-ray or I'm going to get a blood test. I'm going to see you back in 2 weeks. If there's something bad, I'm going to call you and have you come in sooner. But if it's not, we'll sit down and talk about it, because I don't like telling people they've got a problem, but I want to be able, if it's something significant, I want to be able to, because if I called you up on the phone, and this one thing, hey, I got your biopsy back and you got some cancer. Oh my gosh, I'm going to die. And you go to the internet, and you search every site, and they have So really, when I call someone with some news, I like to get them in within a day or two, because I don't want them, kind of like a cow. I don't want them ruminating on that and worry, because our minds always go to the worst possible scenario.
Will I be a eunuch?
Yeah. Yeah. Be honest with you, other than guys that take hormones, other than some erection problems and some hot flashes, they carry on their normal activities of daily living.
Dr. Talley,
I would probably die of something else besides
Probably will.
cancer.
Yeah, absolutely. Probably will. Yes,
Dr. Talley, can you talk for a few minutes about the issues of incontinence after having prostate surgery or other issues with incontinence in men?
Let me talk about incontinence in men. And incontinence in women, we'll save that for another, because that is a whole other topic. The biggest concern men have about prostate cancer therapy, okay, is we men are different than, and I'm a doctor, and so I function in sort of a different role. In fact, that when you talk to men about their prostate cancer, what's the first thing that comes to their mind? Impotence, okay? And then their incontinence, and then their cancer, okay? That's it. Impotence, incontinence, cancer. We need to flip that, boys and girls. People don't die from being impotent, and they don't die from being incontinent. They die from the cancer. There is some quality of life, but as I tell people, as a believer in Christ, I don't fear dying. It's a dying process. I just want to have as long time as He's given me, but when it gets toward the end, I don't want to be miserable. I tell people also that, along those lines, the incontinence is something that my order is cancer, incontinence, and impotence. Because I will tell you, an incontinent man or an incontinent woman are not happy people. Okay? My father had prostate cancer. He had a radical prostatectomy from one of my mentors in Houston and was incontinent afterwards. And he was miserable. He actually died almost 2 years after his radical prostatectomy from a stroke. Had nothing to do with his prostate cancer. And I showed this to people. He leaked like a sieve, and he was miserable. He actually told my mother, if I had this all to do over again, there's no way I would do this. It can happen. The risk now of incontinence is so much less than it used to be. One of the things that I think has changed it are our techniques, our surgical techniques. I have to, pat one of my partners on the back here. I haven't taken a prostate cancer out in about 5 years now, almost 6 years. Oh my gosh, what do you do? I have a partner by the name of Naveen Kella. Dr. Kella is a urologist, but he did a special fellowship training in radical robotic prostatectomy, the Da Vinci robotic assisted laparoscopic prostatectomy. And say, what is that? When I trained, we took it out through a big incision. It was bloody. Catheter was in for 2 weeks. You were in the hospital 3 to 4 days, and you were out of work for about 8 weeks. Dr. Kella actually does this through about 5 little dime-sized incisions about this big. You go home the next day. Your catheter comes out in a week, and most guys are back to work in 2 weeks. It's just dramatic. The incontinence that Naveen has, he's done. There's not probably anybody in this part of the southern United States who's done as many as he's done. Probably close to 600 of these in the last 5 years. He's just, and it's like anything. The more you do, the better you get. The actual OR time is actually probably a little shorter than the open. His average blood loss is about, it's about half of one of these, 150 cc's, versus the old way was about 1 liter, which was about 10 of these, So it's just, with less bleeding, he has a better chance of saving the nerves because they're using about a 20-power magnification. So for those guys, and I look guys straight in the eye and say, look, you don't want me taking out your prostate. And they're like, what do you mean, Doc? I said, look, you got to get up in the morning and look yourself in the eye and say, did I do the right thing? And the answer is yes. Now, there are guys, and I don't mean to sound disparaging, but I would say it as it is. There are guys in this city, there's guys in this state, they call themselves robotic prostatectomy doctors. I've done robotic. How many have you done? Well, I've done a lot. How many do you do? I've done a lot. Tell me a number. There's a guy, one of my patients who went to see a guy, and, well, I've done 9. Okay. Well, Kella does 9 in a week. I mean, he's got guys coming from all over the country. I want that guy that's done 9 a week, not 9 total. And so there's no question the learning curve. And that's why I tell people that in my group, we've pretty much all quit doing them. Because when you see these guys come back, it's just amazing. I tell the story. This friend of mine, and I'm not sharing anything that he hasn't shared from the pulpit. A friend of mine at church, he's our music director, young guy, had prostate cancer. And he had his prostate taken out a year ago on November the 15th. And this was about 2 weeks before the big, and I go to a very large church, the big Christmas production. He had his prostate taken out on a Wednesday, and less than 14 days later, he was back in the pulpit. I mean, back to normal,
Less side effects.
Much less side effects. Is surgery for everybody? Absolutely not. Absolutely not. With the advances in radiation therapy, the other therapies include radiation therapy. There are 2 types. There's seed therapy, and there's what's called IMRT, and then there's also cryotherapy, which has some problems. There's some stuff you're going to be reading about. We've just finished. I'm actually the principal investigator. I've treated about 8 guys already as what's called HIFU, which stands for high-intensity focused ultrasound of the prostate. It's a part of an FDA trial we're doing. I think it's going to be one of the new cutting-edge things. Less and less guys are having surgery. There's no question. But every treatment, okay, when you meet a doctor that says, you need surgery or you need radiation, run from them. An honest doctor will sit down and say, here are all the options. And that's what surgery, there's radiation, both types of radiation, there's cryo, there's observation, there's hormones, there's all these choices. Every patient is different, and you have to individualize. You can't cookie-cutter treatment people, because there are some patients who say, I'd rather you put a gun to my head and pull the trigger than me have this complication. And so when I counsel people, my typical role goes like something like this. So I call them up, we talk about the prostate cancer. I have them come by the office and pick up a book, let them read through it, let them kind of digest this, because when you tell people about cancer, and you've been through there, your head's spinning like a top. And then we sit down for about an hour, and I go through all the different treatment options. And I say, now, I want you to go home, and I want you to chew on this. And I want you to think about all the different options, okay? And after you think about all the options, I want to see you back in about a week or two, okay? Prostate cancer is slow going, and we're going to have time for you to kind of process through this. And we go through all the pros and cons, and then I tell them, I say, look, you go home, you pray about it, you think about it, you talk to guys you go to church with, talk to guys you go to lodge with, talk to guys you play golf with, talk to guys you live in the neighborhood with. You're going to find all those guys, and you get all that information, and you think about it, and then you sit down with a list of paper, and you write all the pros for treatment A and all the pros for treatment B and the cons. And if there's a treatment that has a con that you can't live with, don't choose that. And then I sit down and talk, and they say, what do you think? And I said, I have guys that say, Doc, I want treatment. I say, here's treatment A, B, C, D, and E. And they say, I want B. And I said, that's great. And they'll say to me, what do you think? I said, I think probably C with what you have is probably the best. I want J. And I tell them, that's fine with me. Okay. I think patients understand there can be complications with any kind of treatment. I think patients, through no question, can deal with a complication if they're part of making that decision and if they're kind of strong-armed into having something done. And so I think that's having the patient intimately involved. You know, true story. I had a guy with prostate cancer, and it was pretty significant prostate cancer. He wanted to treat it with green tea and some herb extract he found. And he said, what do you think? I said, I think you're crazy, but that's okay. He said, you're not going to try to talk me out of it? I said, no, you've already made your mind up. I said, but you got to bring your family in here. We've got to talk. He said, you're going to try to talk me out of this. I said, I've already tried to talk you out of it. You're not going to make the decision. He said, why do you want to talk to my family? I said, I want them to know that I wasn't part of this. You know, because when patients have complications, I'm sitting at the bedside dealing with their family going, what kind of nut treats their patients with, you know, and so that's okay. And I've had patients that have absolutely refused therapy. They said, you're not going to treat me. I'm not going to have your treatment. And I don't have a problem with that. I just document that's what they want. Because, you know, I think that's the problem, and I can get on my soapbox about medical care in this country. I tell you, you know, I pick, you know, one of you, I say, you need a biopsy of your prostate because your PSA is elevated. And you don't come back to my office. I don't want to go back to that guy's office because, you know, and in 4 years you show up with prostate cancer, and your attorney calls me and says, why didn't you biopsy his prostate? He's a big boy. You know, I tell you, these are my recommendations, and so we need to take a little responsibility. And if patients want to take the responsibility and, you know, use daffodil juice on it, I don't have a problem with that.
Dr. Talley, we've had a few questions from individuals that are watching this from distant sites today. And one of them you've touched on, and that is, do you believe in anything in regards to alternative medicine?
I think the answer is yes and no. I think, yes, we in medicine don't know everything, okay? If you find a doctor, like I said, who knows everything and guarantees no complications, run from them because they really don't know what they're talking about. I think the answer is we are looking at that. We don't have any hard and fast data on that. I tell people, before you start looking at something, I mean, there's the guys, I love to watch them on TV. They're hawking their vitamins, or I actually know a urologist in Florida that sells his vitamins. And I asked him, I said, how did you come up with it? Well, it's a formulation I came up with. I said, well, where did you learn about that? Well, I just came up with it. Okay. You know, it doesn't make sense. I'm a big believer in when you treat people with a treatment, there should be some science to it, i.e., we have a treatment for, I don't know, shingles, and we're going to use what we think is the treatment and what we think is a placebo, and we're going to take 50 people, and we're going to put half on treatment and half on placebo and see if there's any changes. And if there's changes and it improves, great. There are some data that would support maybe using zinc might help prevent it, maybe selenium, low-fat diet. But as far as alternative holistic and what am I trying to think of, homeopathic, there's no real data to support that at this point.
Okay. And another question that came from us from Del Rio is there any insurance coverage for penile implants or the medications for ED?
Again, that's a twofold question. Let me take the second part of the question first. Treatment for erectile dysfunction orally. Oral therapy is basically starting in 2007. Medicare has taken all PDE5 inhibitor therapy off of coverage. Their theory is people don't die from not having erections, so Congress and Senate and everybody is looking for it. The military guys can still get it on base. There are some insurance companies that cover it. My gut feeling is in the next 3 or 4 years, you're going to see that funding go away. Because, and I hate to sound cold-blooded about this, but I had a patient in my office. We had to discuss, Doc, that stuff's expensive. And I said to him, how much was a Cialis tablet? He said, it's $8. I said, okay. If you go to Whataburger, if you have a Coke and a burger and fries, it's about $8. So if I have the choice of having sex tonight and a peanut butter sandwich for lunch, or a Whataburger and no sex, I can tell you which one I'm going to choose, And that sounds kind of cool, but I've used that as an analogy. But the answer is some insurance companies do. They are really copping that off because the feds have already cut that from Medicare. The answer is Medicare leads, everybody else follows. The answer as far as the penile implants, most Medicare coverages do not cover that. Some insurance companies don't. Most Medicare do cover it, and you would have to sit down, and Medicare does cover penile implants, but Roy Jones, who's my partner, he does all these now because he's so good at them, and it's, like I said, he's like one of the number 3 guys in the nation. There has to do with the diagnosis of what you have erectile dysfunction for, general after surgery, and most Medicare does cover that, yes. But I encourage guys, when you get an implant, if you go for an implant, ask the guy how many he's doing of these a year. Because I tell you, in my group, I'm fortunate. There's 24 of us, and each of us have kind of evolved into specialty. You can't know and do everything anymore. Those days are gone with. If you meet a doctor who says, I can do everything, you become a jack of all trade and master of none. And in my group, I've been really blessed because I have guys who, I've got guys in my group that do the laparoscopic prostates, and I send those guys there. And they send some of their laser prostate stuff and some of their male infertility and their BPH to me. And I've got a partner by the name of Bill Harmon, who I think is probably one of the most gifted laparoscopic surgeon I've ever met in my life. And this guy can take a kidney out that we used to make an incision like this for out of 3 poke holes about that big. It's just, and you're back to work in a week versus 8 weeks. And so I think that the evolution of this has changed to where you find a group like ours that I'm blessed that you can find people who have real expertise who do a bunch of it. And there's some guys out there, they do a little bit of everything. But I think that to answer your question, I send people to see Roy for the prosthesis, and you would have to check with your insurance coverage. Some insurance companies do, some don't.
Thank you.
Anybody else? Questions? No? Thank you guys for letting me come. If you'd like me to come back, I'd love to come back, and I'll send around a while and we'll visit for a little bit. Thank you so much for having me.